Okay, let's unpack this. We're diving deep into pancreatic cystic lesions, PCLs.
Right.
They're increasingly popping up incidentally on imaging.
All the time.
And the challenge, as we all know, is their overlapping features.
Yeah.
But, a crucial subset harbors significant malignant potential.
Exactly. For us as abdominal radiologists, the real mission here is navigating that differential.
It really is.
And what's fascinating is how our advanced imaging has made us so good at finding them. So now the burden shifts to, precise characterization and risk stratification.
That's the goal of this deep dive, really.
Yeah.
Guiding you through those key imaging findings across modalities.
Helping differentiate these varied pancreatic masses.
Okay, so thinking about our imaging toolkit, let's start where many cases begin. CT.
Sure. Widely available. Great for that initial look.
And crucial for spotting calcifications, right?
Yeah.
Like that classic central stellate pattern you might see in a serous acidinoma.
Or the peripheral, sometimes lamellated calcifications, more typical of an MCN, a mucinous cystic neoplasm.
Good point. But CT can sometimes fall short for really subtle things.
Like fine septations or small mural nodules, yeah.
And that's precisely where MRI and MRCP really step up.
Yeah, absolutely. Superior soft tissue contrast, multiplanar, and no ionizing radiation, which is always a plus.
Definitely. They're just preferred for that detailed characterization.
And MRCP especially gives an unparalleled look at pancreatic duct communication.
Which is so critical for differentiating many PCLs.
Couldn't agree more.
Then we have ultrasound, particularly EUS.
Right. Transabdominal US is, okay for surveillance maybe.
But endoscopic ultrasound, EUS, that's where the high-resolution magic happens.
It's the most accurate, really. Lets you see internal features exquisitely, septations, mural nodules.
And crucially guides FNA, the fine needle aspiration, for cyst fluid analysis.
Yeah, that fluid tells us so much. Biochemical, cytology, even molecular markers now.
We also shouldn't overlook PPT-CT. Its role is, evolving.
It assesses metabolic activity. 18-FDG uptake helps differentiate benign from malignant, especially if morphology is equivocal.
And it has a high negative predictive value.
Which can be really reassuring, ruling out malignancy in tricky cases.
Okay, now for the real detective work, the differential diagnosis. Let's start non-neoplastic.
Pseudocysts. By far the most common.
Almost always a history of pancreatitis there.
Definitely. On CT, you'll see that thin, enhancing fibrous capsule, fluid usually less than 20 Hounsfield units.
Though it can be higher with hemorrhage, right?
Exactly. MRI shows T2 hyperintensity, bright signal, no enhancing, solid bits.
And EUS FNA, high amylase.
But the key biological difference, no epithelial lining, just fibrous tissue.
Right. In contrast, serous cystadenomas, benign, often older women, often in the head.
Microcystic. That classic honeycomb or sponge-like appearance.
And if you see it, that pathognomonic central stellate scar with calcification, maybe 10-30% of cases.
Around that, yeah. Importantly, no duct communication. FNA shows very low amylase in CEA.
Okay, moving to the neoplastic side. Mucinous cysts, IPMNs, are huge.
Intraductal papillary mucinous neoplasms, the absolute critical feature, communication with the pancreatic duct.
Essential. Main duct IPMNs show diffuse or segmental MPD dilation. Over 1.5 centimeters is a big red flag. High malignant potential.
High potential, absolutely. Then branch duct IPMNs, beady IPMNs, often give that cluster of grapes look.
And they communicate with a non-dilated main duct.
Key distinction. Now, mucinous cystic neoplasms, MCNs.
Almost exclusively female, 9.1 ratio, usually body or tail.
Right. Large, multilocular macrocysts. Fewer locules than SCA, maybe less than 6, but larger, often over 2 centimeters.
You often see enhancing septations, mural nodules.
And those peripheral or lamellated calcifications we mentioned earlier?
Critically, MCNs do not communicate with the pancreatic duct.
Correct. And given their malignant potential, they're generally considered surgical lesions. Low amylase, high CEA on FNA helps confirm.
Good summary. Let's not forget the non-mucinous neoplastic cysts, SPNs.
Solid pseudopapillary neoplasms. Often young women, body tail. Complex, heterogeneous, solid cystic mass.
Usually well-demarcated, encapsulated. Peripheral solid components, often central hemorrhage or degeneration.
Generally low malignant potential. Then there are cystic pancreatic neuroendocrine neoplasms, CPNETs.
Think thick, arterially enhancing wall. Non-communicating. Variable malignant potential.
And for a really aggressive picture, ductal adenocarcinoma with cystic degeneration.
Rare presentation. but highly malignant. You see this hypovascular, infiltrative soft tissue mass.
With complex cystic areas from necrosis or obstruction, aggressive features, vascular invasion, ductal obstruction, not subtle usually.
Which brings us neatly to the high-risk and worrisome imaging features for malignancy we need to actively look for.
Top of the list, enhancing mural nodules or any solid component within the cyst.
Huge red flag. Main pancreatic duct dilatation is critical too. Over 5 millimeters worrisome.
And 10 millimeters or more, or an abrupt change in diameter, that's high-risk stigmata.
Cyst size matters too. Generally over 3 to 4 centimeters raises concern.
Significant interval growth on serial imaging.
Those peripheral calcifications, especially in MCNs.
And, of course, positive cytology on cyst fluid aspiration. All point towards needing more aggressive workup or intervention.
So wrapping this up, what does this all mean for us radiologists? The complexity here, it just demands a meticulous, integrated approach.
Absolutely. You have to combine everything. The imaging features across modalities, patient demographics, clinical history.
And often, that invaluable cyst fluid analysis from EUS FNA.
Which raises a really important question moving forward, doesn't it? In this era of evolving guidelines, more focus on molecular markers, KRAS, GNS mutations. How will we continue to adapt?
Adapt our multi-parametric assessment, you mean, to truly personalize management and surveillance.
Exactly, and not just looking at the cyst, but considering the whole pancreas for, de novo carcinogenesis risks.
It's a continuous challenge.
Yeah.
Our expertise remains absolutely paramount in navigating